So welcome everybody to today's International Science Symposium. Carl Sagan, a person who has provided great inspiration to me and many others, said exploration is in our nature. We began as wanderers and we are wanderers still. We have lingered long enough on the shores of the cosmic ocean. We are ready at last to set sail for the stars. My dear friend and colleague, Professor Bev Orser, and I have the honor of hosting the International Science Symposium at the 2022 IARS meeting with a focus on space medicine. In order to derive maximum benefit from our expert panel, we will briefly introduce today's speaker and then get on with the program. There will be time for discussions and for questions after the talk, so please use the chat function to communicate your questions. Our first speaker today is Dr. Jim Bagian. Dr. Bagian is the founding director of the Center for Risk Analysis, Informed Decision Engineering, and the Center for Healthcare Engineering and Patient Safety at the University of Michigan. As a NASA astronaut for over 15 years, he's a veteran of 2 space shuttle missions, including as the lead mission specialist for the first dedicated life sciences space lab mission. Following the 1986 Challenger space shuttle mishap, he served as an investigator and dove and supervised the capsule and crew recovery from the ocean floor. He also served as the chief flight surgeon and medical consultant for the space shuttle Columbia after the investigation occurred for its accident in 2003. Dr. Bagian was elected to chair the Joint Commission's Patient Safety Advisory Group and was the founding co-chair of the ACGME Clinical Learning Environment Review Committee, as well as being a member of NASA's Aerospace Safety Advisory Panel. He is a fellow of the Aerospace Medical Association and an elected member of the National Academy of Engineering and the National Academy of Medicine.
Right. Thank you, Michael. It is my pleasure and honor to introduce Dr. J.D. Polk, who's the Chief Health and Medical Officer of NASA, which is the National Aeronautics and Space Administration. And he's the former Dean of Medicine for Des Moines University College of Osteopathic Medicine. Prior to his work in Des Moines at Des Moines University, he was the Acting Assistant Secretary for Health Affairs and Chief Medical Officer of the U.S. Department of Homeland Security. He's a fellow of the American College of Osteopathic Emergency Physicians, a fellow of the Aerospace Medicine Association, and a fellow of Extreme and Wilderness Medicine. He received his degree from the Osteopathic Medicine at A.T. Still University in Missouri and completed residency in emergency medicine, and then completed training in aerospace medicine at the University of Texas. He is triple certified in emergency medicine and aerospace medicine and holds a master's degree in space studies, a master's in medical management, and a master's certificate in public health. Dr. Polk has received numerous awards and commendations, including citations from the Federal Bureau of Investigation, the White House Medical Unit, and the Association of Air Medical Services, U.S. Air Force. He's also received NASA's Center Director's Commendation, the NASA Exceptional Service Award, the National Security and International Affairs Medal, the National Exceptional Achievement Medal, and the NASA Outstanding Leadership Medal. So I am very honored, we are all very honored to have him join us to share his experiences, insights, and perspectives. So thank you, Dr. Polk.
And our third amazing speaker today is Dr. Joan Saary. Dr. Saary is Director of the Division of Occupational Medicine and an Associate Professor in the Department of Medicine at the University of Toronto. She's a consultant to the Royal Canadian Air Force, the Canadian Forces Environmental Medicine Establishment, and the Canadian Space Agency. Dr. Saary is an occupational medicine specialist and an expert in extreme environments. She also oversees aerospace medicine education initiatives at the Temerty Faculty of Medicine. She serves as chair of aerospace medicine at the Royal College of Physicians and Surgeons of Canada and is a past president of the Occupational Medicine Specialists of Canada. Professor Saary is a consultant to the Canadian Armed Forces and the Canadian Space Agency. She was recently named one of the top 25 women in defense by Esprit de Corps magazine. So with those brief introductions, we're happy to go on to the speeches. I'm sure you will be as excited as we are that this incredible panel of experts has come to speak at today's IARS meeting. Thank you very much.
Hi, I'm Jim Bagian, and I'm pleased to be able to speak today at the International Space Symposium. And I'll talk about space medicine, and really I'll say aerospace medicine because I think that's a more inclusive term. I'm a professor at the University of Michigan in the departments of anesthesiology, industrial and operations engineering, and aerospace medicine. And I have no really relevant conflicts of interest, and I won't in any way during my presentation talk about off-label or investigational use of drugs or devices. I think it's probably best to start first at the beginning what the goal is, or really to quote the Cheshire Cat, if you don't know where you're going, any path will take you there. So I think it's important to know what the goal of aerospace medicine is, and that's really to promote the safety and effectiveness of humans exposed to the stressors of flight. In my brief presentation, I'll talk about the historical perspective of aerospace medicine and where it came from, the role of aerospace medicine, both historically and in the future, tools and techniques that are employed, the stressors and environmental and physiologic influences and hazards that we have to deal with, and how we're preparing for the future. Historically, if you look at the beginning of what became aerospace medicine, I think many people would agree that it was the Montgolfier brothers in France and their work with balloons that really set the stage in 1783. And this shows an artist's conception of the one of the balloons they made, which was made of paper and silk. And it was used with a fire at the base that would generate smoke, because they thought it was the smoke and the density of the smoke that caused the balloon to go aloft, not the difference in density due to heating the air, which showed the level of understanding of what was at play from a physics standpoint. And in one of the first times they tried it, it burnt the base through, so it just took off by itself without anything attached to it. They then wanted to fly a person, and Louis XVI directed them to use condemned criminals because they didn't want to risk a human who was not a prisoner or of less worth to society, I suppose. De Rosier intervened with the king and said he thought it was inappropriate to give the honor of the first flight to condemned criminals. So instead they flew a rooster, a duck, and a sheep. They flew successfully and were rewarded for their successful flight by, instead of being butchered for consumption later, they lived their natural lives out in a menagerie. After this, de Rosier actually got to fly on the balloon that looked like this. And they would actually feed the fire in the base of the balloon from the platform you see at the bottom of the balloon. And they flew about 5.5 miles and attained an altitude of 500 feet and survived that. Unfortunately, de Rosier died not too long after this when he tried to go across the English Channel and was unsuccessful. The real generally considered father of aerospace medicine was Paul Bert, another Frenchman who in the mid-19th century was studying the effects of people in flight and really wrote about hypoxia and the effect of flight and dispersation, that is reduced atmospheric pressure, that called what they would generally call bends at that time, and later was known as Caisson's disease, and was involved in the how we successfully did work in caves, tunnels, and building the Brooklyn Bridge, for example. Aviation medicine really began to accelerate in what was accomplished was in World War I and World War II. Up to that time, balloons and aircraft were thought principally to be used for observation and reconnaissance, and that was true in the Civil War. It was true in continental wars in Europe in the late 19th century. But when we got to the heavier airships, we, in short order in World War I, went from observation to actually being used to deliver weapons, shoot other planes down or other balloons down to other observation platforms. And aerospace medicine really became involved both in the development formulation of equipment, procedures, airframe design, and crew medical standards to try to understand what people in a very rudimentary way would be best suited to operate these aeronautical vehicles. Those same motivations have continued through into spaceflight of today. So what's the mission of aerospace medicine? As we said a little bit ago, it's to promote the safety and effectiveness of humans exposed to the stressors of flight. Now, this is where aerospace medicine and the subspecialty of aerospace medicine is in the College of Preventive Medicine. And this kind of makes sense because most of it is directed at trying to prevent problems before they occur. And it's concerned not just with the health of the individual, though that's certainly part of it, but also the success of the mission. So there's a certain organizational responsibility for mission success that underlies and is really the underlying motivation for most of the things that were done in aerospace medicine. It was done primarily to get the functional outcome of the mission, not principally just for the individual himself. It was because of what flight caused to the individuals. And this would involve everything from the pre-flight activities took place to in-flight operations and how to mitigate problems or help resolve problems once they occurred. And then post-flight, what we could learn from those, both for future reference, as well as to treat sometimes maladies that occurred as a result of the flight itself. This extends not just to flight personnel, but especially in space medicine, to the ground personnel as well, because they often have some of the same extended work periods, communication problems, interpersonal relation issues that come into the successful achievement of the mission. On the other hand, you have, that I've alluded to before, the responsibility of the crew, and that is for crew health itself. Now, this is certainly important, but it does not preclude the mission success, and these have to be carefully balanced. And this requires really a systems risk management type of approach. So there's inherent conflict of interest here, and that's you have the risk to the organization and the success of the mission, and then you have the individual risk. And really, the people in aerospace medicine and those that are involved in this, and this goes from physicians to aerospace physiologists, for example, or psychologists, have to really look at the interventions and how they can prevent problems, ameliorate the problems that can occur, or deal with the aftermath of them. In spaceflight, the two things they talk about primarily are loss of crew or loss of mission. And in peacetime type flights and for investigational flights, these are usually related to loss of crew as the overarching one, and loss of mission is slightly less priority, but that is not always the case. And certainly in military situations, it's clear that often we know we're going to have loss of crew, but the mission needs to be accomplished. And we try to figure out how to best accomplish the mission and maintain the welfare of the crew as best we can and still serve the mission. So once again, this requires involvement from both the planning through execution, and then in the aftermath, the lessons learned for application in the future. And it requires involvement of the aerospace medicine individuals that are involved with this task in coming up with what is acceptable, the acceptance of residual risk. What's the acceptable level of residual risk that can be used? And this is how you relate the lock, the loss of crew, and loss of mission LOM, and how do we get to that point? So some of the tools that we use and techniques, the thing that governs all this is the challenge is the in-flight N that we have. The number of people we have to examine is small, and the access to them is limited, and it happens over many years. So to get a meaningful N is really not always possible. We use bench testing on the ground, and in orbit, we use ground-based tests that we try to understand in flight, both terrestrial flight, I'll call it atmospheric flight, as well as space flight. As I say, the availability of both in planes and especially in actual space, orbital, or trans celestial body flight is very limited. And then ground analogs that we can use. This is a slide that goes back to 1981, and I think it still is apropos. And it's NASA how they say the environment and the stressors we deal with. On Earth, we know what those are. And if we look in the vehicle, because we can take our own environment with us to a large extent, it's much the same, except that we don't really have the resultant of gravity. So people think about their weightless, or you can think about they're actually in free projectile motion, so they're in constant free fall, but at micro G, or effectively weightlessness. And if you're out in space without the spacecraft, you basically have nothing except the the infrared radiation, UV radiation, the ionizing radiation, X-rays, and intergalactic rays, radiation, and light. So quite a difference in the environments you're exposed to. So traditionally in atmospheric flight, we worry about things like temperature, pressure, acceleration, both positive and negative, fatigue, circadian rhythms, things of that nature. And these affected the cardiopulmonary system, the autovestibular system, visual systems, and cognitive and perceptual problems on the part of the crew members. So these went into simple things like hearing protection from noise, how to keep people as best we could from being motion sick or disoriented due to the Coriolis effect of accelerated flight while in doing turns and things of that nature, and the cardiovascular demands. And these became fairly well understood as we got to the end of World War II. Before that, not so much. When we got to space flight, we had these same influences, but then we had the issue of what, as I described before, weightlessness, or this micro G. And then we started to see phenomena that their symptoms may have resembled some of the things we saw in atmospheric or terrestrial application, but not quite the same. And these got the space motion sickness, disequilibrium on return to a 1G environment, bone metabolism, calcium loss, musculoskeletal deconditioning, visual changes, we think due to increased intracranial pressure due to being in a weightless environment, and hematologic and immunologic issues. Also, one of the big ones is radiation and psychosocial issues having to do with crew coordination, being in stressful environments, both physically stressful as well as psychologically stressful in closed environments for days, weeks, months, or possibly years. Some examples that I can talk about a little bit are orthostatic hypotension on reentry, which we've seen for quite a few years, and I was involved in a lot of this research, and both on ground and for preparation for space shuttle flight, as well as I was in charge of, from a crew standpoint, of how we put the first space lab together, first physiologic lab in space. And this shows one we did looking at baroreflex. And what you see here is, as you go up in the y-axis, the RR interval increases, or you can think of bradycardia as you go up. And as you go right to left, the descending pressure of the carotid sinus goes up. So if you have people pre-flight where they are in a normal gravitational field, you'll see there's a somewhat sigmoidal shape to the curve. So as the carotid sinus is stressed, the heart rate slows down, and we're aware of that. But we see when you go to post-flight that's much blended, and we actually see after the first couple of days in flight, we saw in experiments that as we would change the transmural pressure, that the reaction became much less risk. So you didn't get a cardiac acceleration to a hypotensive load. Similarly, we saw the distribution of fluid in the central system. Basically, you would see just schematically, and one would be ground-based. And then you see when you get to orbit, because the normal elastic recoil with no actual hydrostatic force due to gravity, you see the cephalad shift of fluid. You see a diuresis when you get to 3 within the first day. You'll see almost a 1,000 cc loss of intravascular volume, and that's normal there. And the edema will go down, facial edema will go down, limb girth will go down, especially in the lower extremities. And then when you return them in a short order, you'll see that they now basically are like they're 1,000 cc's low in intravascular volume and don't get this cardiac acceleration, which leads to hypotension. Now, I was in charge of doing the research in the late 70s before the first shuttle, and we show that using a G suit, as was developed in World War II, and later mask trousers were just a takeoff of that, just using that either prophylactic or symptomatically at a pressure of about 50 torr was enough to prevent any kind of syncopal or pre-syncopal episodes. The correlation, though, goes to ground, and that is that this is what we see in bed rest. And there have been unknown, I think, to many physicians, and even when I was there and after my anesthesia residency, people used to talk about people that were, bed rest for long periods of time would tend to be more orthostatic intolerant. You had to be careful when you anesthetize them, as if this was something we knew about, but it hadn't been well studied. And actually it had. There had been bed rest studies going weeks and months that showed that orthostatic intolerance after bed rest was there. There was a less brisk autonomic response and loss of intravascular volume. So these are things where we actually kind of learned them by experience, but often weren't taught in a way as if we knew about them. It was just divorced between what aerospace medicine was understanding and what we applied in clinical medicine in many cases, and vice versa. The other thing we looked at was space motion sickness. And here we had a situation where when people were in orbit, 75% of first-time flyers would get sick, 50% of veterans, The etiology was a sensory conflict like we see in a terrestrial environment or fluid shift. It's still, we think it's some of both. And then there's the academic approach of research where we never could come up with a good, what seemed to be a ground-based way to do this, to show what worked, and the treatments, none of them worked. And then when I flew my first flight, I advocated for, let's take a more risk-based approach. And can we use some things we used on Earth without extensive testing that we thought the downside to using them might be better? And after discussing with our flight medicine guys, they agreed. And we actually tried using promethazine. Before that, we tried scopolamine, Scopedex, things like that. None of them worked, though they worked in the terrestrial environment very well. We used promethazine, and we took amphetamine in case we needed to use it to antagonize a sedative effect, and promethazine worked great. And since then, we've done other controlled studies in the past years. This was done in 1989 originally, and it's still the treatment of choice. So I give those as two examples, more like a theoretic way of looking at it on the ground versus an applied way to get us where we need to get. We still have things that are unknown, many of them, and the most important ones are the visual changes we're seeing, which some appear to be some permanence to them, and we think is due to ICP. Radiation effects are still an issue, and how to really look at that. What is the level of risk we should take, and the psychosocial issues of crew dynamics in a closed environment for a long period of time. So, in order to be successful for extraterrestrial flight, going to Mars, going to bases to the moon, we have to consider these things, and these are challenges and opportunities that will require, and the continual clear, concise, and compelling goals that guide what we do. A proactive look at risk, where we try to mitigate what we can and what we have to accept, and make sure we clearly explain that, and the rationale for what that is, from planning through execution. So we bring along all the stakeholders we need to, and this is iterative, and we always need to include the rationale so we can really have a useful, informed discussion among all the people involved, not just in the operations, but the funders, the public, the press, et cetera. And in this way, we can really make best use of what we learn in a terrestrial clinical area to guide us in flight and operationally, and vice versa, as I talked about, for instance, with the space motion sickness. And if we do this using a systems-based approach, which must be foundational to our success, we should proceed in a reasonable way. And this same kind of approach is what we see even, I think, when we look at increasing the quality and care of medicine, the same system-based approach. Thank you very much for your attention, and I look forward to discussions we can have later regarding this.
Hi, I'm Dr. J.D. Polk. I'm the Chief Medical Officer of NASA. And let me go ahead and start sharing this screen. There we go. So, how do we perform these missions? How do you start on a space mission? How do you plan for going to the moon or Mars? And as you can imagine, at NASA, it is not guesswork. We don't just say, hey, let's fly this medication or that medication. There's a lot that goes into the analytics behind the scenes to decide what medications we'll take, what medical procedures we need to be prepared for, what things do we train the astronauts to do medically. And so let's get started. First, on the disclaimers, I have no financial conflicts of interest. This next disclaimer I always have to laugh at. They always ask if you have any off-label use items. There is no label from the FDA or on any medication that says for use in outer space. So technically, everything I do is an off-label use. This is the centerpiece of what we're doing right now at the International Space Station. The International Space Station over the last 20 years has allowed us to learn how to live and work in space, how to put different modules together made by different countries, how to develop standards to where something that's being built in another country will then fit for the first time in outer space with something else in another module. So this is really where we've learned a lot about the human system and the changes in physiology that occur at the 6 months and now 1 year level. Mark Vande Hei comes home after 1 year in space. So this has really been a good proving ground for us. And of course, 250 nautical miles, 17,000 miles per hour, 26 countries in 20 years and counting. The interesting thing, I can get medical data. I can get pictures of the back of the retina from somebody's eye. from this International Space Station, our clinic, if you will, at 250 nautical miles above the Earth, traveling at 17,500 miles an hour. I can get that data on the console, on the surgeon console, and they can distribute that out to different clinics or hospitals or to the chief medical officer to look at, to be aware of. So those clinics that can't talk to each other, or the hospital, or can't get their EMR to work across the street, I don't have a lot of sympathy for. We do a lot of commercial crew work. We pay for and develop the standards and requirements for several commercial vendors, including SpaceX and Boeing, and many more now for the Human Lander System and Gateway, Lockheed Martin, and multiple others, SpaceX and Sierra Nevada, many others involved in either cargo, transport of humans, or development of our lunar architecture now. And this is the SLS, one of the most powerful rockets ever built, if not the most powerful rocket ever built, that rolls out. By the time this lecture is given, it will have rolled out from the vehicle assembly building, heading for the pad. And this will launch in June, going back to the moon. It's a very, very powerful rocket, more powerful than the Saturn V, and really looking forward to getting back to the moon and seeing this rocket launch. And of course, getting back to the moon is going to look different than the first time we went with Apollo. We're going back for a more sustained presence. What does that mean? That means living and working for 30 days at a time, but repetitively going back and doing multiple different missions in different areas of the moon, both for science and material science and biological science, and anything else that we can think of that we can use that moon for as a test bed for going to Mars. Not only to learn about the moon, but to use the moon as that architecture to test many of the technologies and the procedures and the things that we're going to do on Mars. And of course, with the moon being closer to Earth, that's a great place to do this test bed. The 1/6G of the moon, if something's going to work in 1/6G, especially on human physiology to prevent bone loss or to help with intracranial pressure or any of those things, then it'll certainly work in the 1/3 G of Mars. So it's a great test bed for us. And of course, we've talked a little bit about it, but there are a lot of physiologic changes. The redistribution of fluid up into the thorax, the body thinks that it's got fluid overload. If you think about all that fluid moving from your legs, triggering your right heart and your carotid bodies, the body thinks it's got too much fluid, and so it starts to decrease and downregulate erythropoietin. There's a little bit of increase in GFR coming across the kidneys. So the astronauts end up being about 2 liters behind on preload when they land 6 months later from the International Space Station. That's why you see them reclined when the Russians take them out. They're certainly orthostatic, and we replace those IV fluids. And they replace them orally as well. But that's definitely a big thing that we see. As Jim has already mentioned, the space motion sickness, now called space adaptation syndrome, which your brain does not get the biofeedback that it normally gets when you're on 1G. And so the ability to keep your eyes with the horizon, or the stretch that you have in the Golgi tendon apparatus of your tendons to tell you if you're leaning forward or back, or the pressure on the balls of your feet, all of those things, all of those proprioceptive things go away. And when you get to microgravity, and the brain gets confused and you have this nausea. Of course, the risk for kidney stones with bone loss. You do have bone loss, Wolff's Law. Bones grow according to the pressure placed upon them. And so since you're not putting as much pressure on those bones as you would in 1G, you start to lose bone. Of course, we do resistive exercise on orbit. We have bisphosphonates. We have other countermeasures that we do to prevent that bone loss and to keep that mineralization of the bones and the integrity and strength of the bones. Intracranial pressure, another thing that we've seen with that fluid shift and the microgravity, an increase in the ICP of astronauts with some vision change, including some Frisson scale grade 1 and 2 papilledema that we've seen in astronauts. And so a lot of these things that we are working on to see what countermeasures are going to work on the moon. Is partial gravity going to help with intracranial pressure? You think it will, but how much does it help? And to see how much of these mitigations and strategies we can use for space physiology before we head to Mars. And that's the big goal. Of course, how we design all of these things, we start with the spaceflight design reference missions. We identify the hazards. We look for the evidence base at how much bone loss there is, what works for bone loss. We examine the risks, and then we develop standards and mitigations. And I'll talk a little bit about these, especially some of these terms of art that we use very often at NASA. And let's start with the design reference mission. So a design reference mission is essentially starting with the outcome or the mission that you want to achieve. Are you going to the moon? How long are you going to stay? What all are you planning to do while you're there? What are the mission objectives you intend to do? Versus going to Mars. And so those could be vastly different. If you're going for 30 days to the moon versus a year and a half or 3 years to Mars, or are you going to low Earth orbit for 6 months? Those are all different physiologic changes. Those are all different logistical things that you have to think about, how much hardware and food and water and other things you have to take with you, different radiation, all of those things. So you start with that design reference mission, and then you develop what are called standards. And I'll talk about those in a second, but you're going to develop standards for the spacecraft and standards for the human to help obtain those mission objectives. Standards are evidence-based shall statements. Think of them as biblical. And in your world in anesthesia, that would be like the oxygen saturation shall never fall below X. And so we have that same thing. We in a spacecraft, you don't want the oxygen saturation to fall too low in an astronaut, or you don't want the environmental oxygen to be below 21%, for example. Although you can allow a little bit of mild decrease in oxygen, just like when you climb a mountain or altitude, it has physiologic consequences and things that occur in the human body as a result of that. And so, you have to counterbalance some of those and balance that risk. And so when we build spacecraft and when we have standards for the human system as well, we have these standards that are thou shalt not cross. And so when SpaceX or Boeing or Lockheed Martin are building a spacecraft, they have that book of standards that they have to adhere to try to make that spacecraft adhere to those standards in order to meet those mission objectives. Now, requirements are a little bit softer. A requirement can be waived or amended, but how you design something to get that requirement or meet that requirement might be different based on the different vendors. Let's say I have a requirement to have a mobile vehicle that will leave the lunar lander and do an excursion within 3 miles of the lander. That design may look very different depending on the vendor. One may look like a small bus, one may look like an electric car, one may look like a dune buggy, like this that we had in Apollo. And so, those requirements account for why the vehicles all look a little bit different in shape and size and flare from the different manufacturers. And those requirements are how you meet that standard. The standard might be that the astronaut have mobility to get back to the lunar lander and be able to do that within X number of minutes, so they don't run out of oxygen or CO2 scrubbing capability. So that might be the standard, but the requirement then of a vehicle that is mobile and et cetera, those can all be tailored based on the different vendors. Now, how NASA views risk, we look at risk really in a way that most others don't. What you're looking at is a 5x5 risk scale, and that depends on the frequency and the severity of something occurring. And so we'll use this color coding, this red, yellow, green, for nearly everything in spaceflight to figure out what is the risk of this occurring. And if something has a high risk, it's high and to the right up in this red area, then we have what's called fault tolerance. We build a system so that if something fails, we've got a backup. And just to explain fault tolerance very quickly, you know, on a commercial aircraft, if the gear does not come down, you've got a backup hydraulic system. And then after we learned from the Sioux City, Iowa mishap and plane crash, they even have a backup system to that. So it's called two fault tolerance. You can have one system fail and you've got a backup, and if the backup fails, you have another system. That's two fault tolerance. And we very often have two fault tolerance in space systems, especially if they are high and to the right for its criticality or its probability of impact. Now, this is kind of an eye chart, but just to give you an idea how we disposition those risks in relation to the human system. So we'll take those design reference mission, low Earth orbit at 6 months, or low Earth orbit at 12 months, or a deep space sortie at 30 days, or lunar visit at 1 year, or deep space journey at 1 year, or planetary, i.e. Mars. And we'll put all of these out, and then we'll look and baseline, how are we with renal stone formation? Well, we're adequate until maybe we get to Mars. This mission, we still have more work to do on the research side or on the medical mitigation side. Space radiation exposure. You notice we get to red here on the Mars habitat as well. And so, we can look at, are we red, yellow, or green? And then, of course, have backup systems, just like you do for the spacecraft. What happens if there's a renal stone? Do we have ultrasound on board? Do we have potassium citrate? Do we have IV fluids? Do we have pain medication? Do we have Toradol to help them pass it? What are the things that we would need if we can't prevent it and it does occur? And we look at that fault tolerance, just the same way that you would have with something with the vehicle. Now, we're also involved in the vehicle development. You would think, why are doctors involved in the vehicle development? One, we have a lot of doctors that are also engineers, so keep that in mind. But we're part of what's called the technical authority because the physiology changes the requirements for the vehicle. If you look at the top half here, this is what an astronaut would see upon launch. And you can read the switches, et cetera. But after that intracranial pressure occurs and that vision change occurs in the back of the retina with that choroidal folds or choroidal edema that occurs and that gives you a 1 or 2 diopter shift, suddenly this is what the astronaut sees when they're coming home after 6 months. Now, you could just fly another eyeglass prescription. You could do a lot of other things to help mitigate that risk, but you could also make the font on the electronics bigger and allow the astronaut to change the font or the size of the font and look at things so that they don't have a human factors error or mistake. And how do we do quality measures? We look at a continuous review process after every mission. We've developed clinical practice guidelines that are unique to the space physiology. We do quality reviews. We have flight rules and checklists that make a lot of the procedures very Six Sigma on orbit to prevent errors. And we have a lot of oversight, crew resource management, and of course the independent technical authority. And that even bleeds over into clinical. This is looking at a clinical chart where we do our clinical quality measures on the astronauts. These are the astronauts at the bottom. And we can tell, based on a clinical practice guideline, if we have a clinical practice guideline for blood pressure, for example, for making sure that nobody goes over 140/80, we can start to see, hey, what's going on with this astronaut here, and who's number 6, and why are they high? Why are they not in the clinical practice guideline, or why is 44 not in the clinical practice guideline? What's occurred there, and can ask their flight surgeon to go look at that. And hey, let's make sure we're not dismissing that as white coat hypertension. There's clearly a trend here with their data set. Let's go look at it. But you can see all the astronauts within that band. And then when you get to cholesterol and lipids, same thing. We might say, hey, what's going on with this one over here or this one? And you find out that maybe the reason that their cholesterol is high is because their HDL is so high. Their total cholesterol is high because they've got an HDL of 100. And we have a couple of astronauts like that where they've got some pretty high HDL versus LDL. And then we watch their total cholesterol over time, and you can see with age and time that goes up. We monitor their C-reactive protein, but we have clinical practice guidelines on a whole host of things based on the risk that those astronauts have. And then how do you forecast the medical needs? And as the previous speakers mentioned, we're benchmarking off of analogs. We're looking at other other folks like the Navy and their undersea and submarine work. We look off of simulations that we do. We do a lot of black swan, kind of worst case scenarios and work backwards. We do directed research. We do a modified Delphi, where we look at all the space missions we've done and get all the experts that have worked on space missions and get their opinion. And then we have what's called an integrated medical model, which is a Monte Carlo analysis to diagnose those things. So the previous speakers have mentioned all the simulations that we do. I won't linger on that, as well as the analogs that we've done. And we do those missions to give us more data to figure out what we'll need to take with us and what we'll need to do. From modeling, as I mentioned, we do a modified Delphi. We do a Monte Carlo analysis. We have what are called directed acyclic graphs. We do benchmarking against analogs. We do simulations testing, and we do a great deal of failure analysis. And that leads us to, what drugs we're going to take and what things that we may have to be prepared to treat on orbit. And the integrated medical model is this Monte Carlo analysis that we do, where we put a ton of data from the Antarctic, the Arctic, all 60 years of our space missions, submarine missions, from the Navy and et cetera, and learn what everybody treated, what everybody had to be prepared for. And then we run millions of simulations and millions of runs to see what the likelihood of certain things occurring, like a kidney stone occurring, or even something as simple as a dental procedure or dental issue occurring, so that we know what those what occurs, what spits out on the other side, all these different diagnoses, and then what the likelihood is. And then on this graph, you can see there's the predicted, which is the red square here, and then there's the observed, what actually observed during spaceflight. And you can see on these 15 conditions, we were spot on. The model predicted it, well within the error bars. We were spot on. But then you look at these conditions, and we over predicted over here and under predicted slightly over here. Now, the ones that I worry about are not the over prediction. Sometimes we over predict, and the reason for that is that we do a robust preventive medicine program on the astronauts. And so it does not surprise me that we might over predict based on, compared to the general population. The one that worries me is when we under predict, when we see things on orbit that we under predicted, and so we have to adjust our model and make sure that we refine that after every mission, so that we're well prepared when we go to the moon or Mars, and we have a good evidence-based way to look at the likelihood of a condition occurring and whether or not we have the medications and things to treat it. And so that also lends itself to these directed acyclic graphs. And what these are, let's talk about one for venous thromboembolism, for example. All the things that can impart risk for venous thromboembolism on orbit. It's an enclosed environment on the space station or on any spacecraft, and you've got a CO2 risk. The CO2 on the spacecraft is about 10 times what it is on the ground. We can scrub CO2, but you can never quite scrub it as efficiently as all of nature does on the ground. But we're continue to work on that from an engineering perspective. So that increased CO2, as all of you know, can cause vasodilation, especially cerebral vasodilation. Does that impart risk for venous thromboembolism when you have a lot of blood and stasis sitting up in the upper body and into the cranium? There's that fluid shift. There's radiation causing oxidative stress. There's all these different things, and we look at what are the different things that can interplay off of each other to affect coagulability and potential venous thrombosis, and then how do we impart or change that risk? What's the medical treatment capability? Do we fly anticoagulants? What if we have to evacuate? All of those things. So we map all of that out to figure out all the different ways that we can impart the risks that go into venous thromboembolism, for example. And of course, we do this directed research, which both of the previous speakers have talked about as well. Obviously, astronauts are limited in. You're not going to have a really high-powered study with 5,000 people in it because we haven't flown that many people in space. So the in and the power is a little bit, decreased, but it's still a clinical imperative for us to do to be able to figure out what we need to fly on different missions. And of course, the International Space Station, we're doing a lot of science on board. This is Kate Rubin sequencing DNA and growing cardiac cells on orbit. We're doing a whole host of things aimed at different diseases. We're studying Parkinson's. We're looking at different bacteria on orbit and different ways to make vaccines. The drug Keytruda was evaluated and tested on orbit. And you can make different proteins and different crystalline structures and different pharmaceuticals and microgravity that you can't make on the ground. So it's an important area for us. We're also looking at different technologies as we go to Mars. This is 3D printing of medications. Instead of taking a massive pharmacy with me that's exposed to a bunch of radiation, can I take either lyophilized drug, or can I take the actual chemical constituents and the recipe for how to make a Cipro and 3D print one? And so those are the things that we're looking at right now. And that's how you start to build space missions, and how we develop and mitigate that risk and work on that risk. And so with that, I think we're about ready for questions.
Thank you very much for inviting me to give this talk. I'm thrilled to be here as part of this panel to speak with you about the topic of space medicine. First, the housekeeping measures. You'll see my disclosures on this slide. Let me start by saying that it's hard to speak about aerospace medicine without a reminder that the human fascination with flight is thought to predate recorded history. Once the realm of hobbyists and eccentrics, and in some ways it probably still is today, no doubt early space medicine likely related mostly to managing injuries. In 1903, the Wright brothers' first flight took place, and thereafter in the 1900s, there was an exponential growth in aviation to the point it became part of everyday life. This parallels Moore's law, described around 1965, which was the observation that the number of transistors on integrated circuits doubles approximately every 2 years. Moore's early observation is important as it showed that technological advances do not progress linearly, but rather exponentially. Technological developments grow exponentially in many disciplines, including aerospace and medicine. There is a saying that necessity is the mother of invention, and this is certainly also true in aviation. For example, Canada's north cannot accommodate conventional runways. Canadian innovation in aviation led to creative ideas such as this: planes on skis. Our northern geography poses challenges to this day. That leads me to comment on the hazards of flight, examples of which are shown in this slide. Unlike practitioners of many medical specialties, where the focus is assessing, diagnosing, and treating ill individuals in a normal environment, specialists in fields such as occupational and aerospace medicine have expertise in keeping people well in hazardous environments. The idea of mitigating risk in space makes us pause to consider the mission priorities and whether this prioritization plays a role in medical screening and research priorities. I often ask audiences how they would prioritize these randomly positioned risks and whether they think a space agency or commercial company would order them differently. And if so, what impact would that have on research funding, for example? Next, I'd like to weave in the mission design concept as well. Even though the exact details of the missions aren't yet confirmed in all cases, we can and should make some educated guesses about what these are likely to be, and we can then define some boundaries. Consider for a moment, how might the various types of missions differ between shuttle, ISS, lunar sortie or habitation, and Mars missions? What is the travel time to the destination, at the destination, and also time to evacuation, if that is even possible? What is the crew composition? How long is the communication delay? All of these things play into our strategies for mitigating risk. And what is risk then? Risk can be visualized in the form of a risk matrix, which risk is equal to the probability of an event occurred multiplied by the impact of that event if it was to occur. And therefore, consideration of medical risk requires us to think about likelihood and severity. So example would be your driver's license. How do we quantify medical risk, and where do we get meaningful data about space-related risks? One way would be actual event data from space, which ideally is kept very low because of risk mitigation. Another is through the awareness of space-related hazards leading to likely health consequences. For example, physical hazards such as radiation and microgravity, noise, vibration, and G exposure, to chemical hazards such as hydrazine, and psychological hazards such as isolation and confinement. One other way to get meaningful data is through analog missions. Some places on Earth are a lot like Mars. Terrestrial sites that resemble the geological, environmental, or biological conditions of a celestial body are called analogs. Such sites are used to do research, evaluate human performance, and test prototypes for technology in space medicine and other disciplines. Why is this important for us on Earth? Well, if we can solve the problem in one environment, we can translate it for use in another. Let's talk more about analogs for a minute. As I mentioned, analogs are sites or situations that resemble in some concrete way the environment of space. These environments may also be analogous to space for other reasons, such as the degree of isolation or confinement, having a requirement for self-sufficiency, or having a communication delay. These scenarios enable testing and research to understand or prevent the effects from a known hazard of space. In fact, the ISS itself could be considered an analog for other more distant missions. As a result, analogs usually fit into one of several categories: isolation and confinement, for example, microgravity, distance from the Earth. And I showed this picture before, comparing it to Mars. It is the Houghton crater on Devon Island in Canada, and is an example of one of the analog sites on Earth. By way of context, Iqaluit is the capital city of the Canadian territory of Nunavut. This city, with a population of just over 7,000, is the political and transportation hub of Nunavut. There are 24 hours of sunshine in late June and early July, and only 4 hours of daylight per day in December. There is an excellent airport, and the landing strip is long enough to land the space shuttle, so it is often used for cold weather testing of the world's largest new aircraft. Take a moment to consider the scale of this map and comparable distances. And since this is a medical discussion, think about the challenges of delivering healthcare here. There is a 35-bed acute care facility serving approximately 16,000 people living in the region, which is home to 12 communities spread over approximately 1 million square kilometers. My dear colleague, Major Ken Hedges, is the last surviving member of the British Trans-Arctic expedition, pictured here rescuing his dog on the Arctic ice. The 4 men and their pack of 40 sled dogs took 476 days to traverse almost 6,000 kilometers and complete the first surface crossing of the long axis of the Arctic Ocean. This expedition occurred only weeks before the July 1969 moon landing. And like the moon landing, it highlighted the realities of survival in a harsh environment and demonstrated how the terrestrial environments, including the Canadian North, are much like space. It also taught us about the impact of isolation on mental health, highlighted again through this recent pandemic. Isolation is one of the significant hazards expected in future long-duration space missions. But how can we actually learn about zero-G without going to the ISS? This is not a rocket in the top picture. It is this armed drop tower at the University of Bremen. Experiments use a specially designed shock-proof pressure and temperature controlled carrier capsule. The capsule can be released or dropped from a height of 120 meters or approximately 394 feet. Giving 4.74 seconds of microgravity experiment time. This is good for experimenting with stuff, but what about people? Parabolic flights are used for larger experiments as well as training. In this situation, the aircraft pilot undertakes what is called a parabolic maneuver by pulling up, arcing over, and pulling out, which results in about 20 seconds of weightlessness over the top. And different parabolas can be used to simulate gravity between 0 and 1 g. Now, getting back to medicine for a moment, there's no flying ICU in space. Imagine what this would look like in a 0G environment. Patient restraint becomes patient and clinician restraint, not to mention mess control. Tools don't work the same way. They float about. Liquid doesn't move the same way. Surface tension creates spherical bubbles, and physiology changes. Fluid shifts caudally. And what about pharmaceutical effectiveness in weightlessness and radiation? And there's no code blue team either. Analogs like parabolic flight are one way to convert this terrestrial ICU into something more practical for space, such as this possible airway kit example shown. This process develops useful understanding about how to deliver medical care with limited mass, power, and volume, which is required in space, but also relevant in many terrestrial environments as well. And what about training? We need an analog for that as well. A spacesuit weighs approximately 280 pounds on the ground, so training to do spacewalks cannot occur terrestrially just by putting the suit on. The solution is a neutral buoyancy situation. In other words, a really, really big pool. This training pool contains 23.5 million liters of water and is 12 meters or 40 feet deep. It can hold a full-size mock-up of the space station and flight payloads such as the Hubble telescope, and allows 2 different training activities at either end of the pool simultaneously. The choreography of a spacewalk is practiced in the suit in the presence of safety divers here in this pool. Outside of the pool, there's also the ocean. The Medina Aquarius program is part of the Florida International University's Marine Education and Research Initiative, and the Aquarius Reef Base is an underwater habitat off Key Largo on the ocean floor. And this is where NEMO missions take place. NEMO is an acronym for NASA Extreme Environment Mission Operations. Saturation diving analog missions, in which groups of astronauts, engineers, and scientists live in Aquarius for up to 3 weeks, take place here. NEMO missions simulate living in a confined space and can test spacewalk tools and techniques in different simulated gravities. As well, working in both space and underwater environments require extensive planning and sophisticated equipment. Now, I've introduced only a few of the many analogs in use today. Clearly, innovations developed for space often have terrestrial benefits, and similarly, terrestrial health and health technology innovations enable health and survival in space. For example, Canadian robotics developed for the International Space Station has inspired health-related spin-off technologies that improve quality of life on Earth. With goals of faster, higher, and further, this often equates to different and greater risk. Recall Moore's law of exponential progress. Recently on the news, we've watched numerous firsts in space, and personally, I think we are essentially resetting the starting point of exponential growth in many areas, which is why I've changed the date from 1900 to 2021. We have exponential growth in accessibility. Now space is not for just professional astronauts. And as we have more travelers, this will increase our understanding of human physiology in space. We have exponential growth in destinations with multiple space stations under construction, which will become new places of employment with different medical care requirements. We have exponential growth in the ways to get there as well with multiple vehicles, and exponential growth in duration. As we extend our time in space, we will gain our understanding of our own capability to adapt and also learn about unanticipated emerging problems. Lastly, we have exponential growth in the level of autonomy, and we really must learn to trust our artificial intelligence. An ancient Chinese philosopher once said, "The journey of 1,000 miles begins with one step." Times are clearly changing, and we are poised once again for exponential growth. We should position ourselves to imagine, define, and participate in the future.
Welcome back, and we'll ask our wonderful speakers to turn their videos on. We have about half an hour left of this session. There's already been lively discussion in the chat, and Dr. Orser and I will moderate the session and try to direct questions to all three of the panelists. Dr. Orser, would you like to kick things off?
Thank you. So thank you for three wonderful talks. Earlier today at the T.H. Selden lecture, we were discussing how to engineer out the human factors. Can you please help us understand what you've learned about the principles to determine the right balance between technology and human capability? How do you find that that balance? I'll open it up to the group.
Well, I'll take a crack at it. I think I don't know that there's one right balance. I think it's an iterative process. And if you look at the history of human space flight, if you go back to Skylab back in the 70s, in the beginning, we didn't have as much sophistication about what we would see. And we had astronauts while they were making sketches of various colors in the Atlantic Ocean. And they took pictures simultaneously. And when they returned to Earth, they saw that the pictures of the water just were like one color blue, basically, and didn't have the rich, variations. And then when they, on subsequent missions, they actually put oceanographic vessels in the parts of the ocean they were looking at. And they saw, in fact, these were cold water upwellings. At that point, the Soviets had understood that and put their fishing fleet in the darker ones because that's where a lot of plankton was for the fishing fleet. And we didn't know. After that time, we understood what frequency spectrum we should look at. We were able to do it much better with remote sensing, and that surpassed the human capability. But in the beginning, we didn't anticipate that, and the flexibility of human enabled us to capitalize on that. So I think that there's a ebb and flow of how you do one versus the other. It's what you want to do, and the human gives you flexibility, but not the same level of precision in many cases that the equipment can do.
Can I add a comment to that, if I may? It just led me to think about human factors in terms of capability and in the medical perspective about a skill fade. And as we think about longer and longer duration missions, how much can a human actually be expected to do and to remember? And so how do we solve that problem of becoming a human encyclopedia? And so one of the things I think that we'll start to see more and more of is development of reliable decision support tools. And we see some of that emerging now, but I think that will continue and become necessary in addition to strategies like just-in-time training and that kind of thing. I think that when we talk about human factors specifically related to, I guess, medical training. So just food for thought there.
Great, thank you for those answers. I'm going to pitch a question now from the chat, and maybe Dr. Polk, you might like to take this. And it's somewhat of a philosophical question from Professor Josh Billings at Vanderbilt, who asks about the effects of space on physiology, stating that they're interesting. And overall, do we know if being in space is helpful or harmful to health? And in supporting the answer, do you know of any differences in hard endpoints?
Yeah, I'd say overall, there's not a lot that's quote unquote helpful, but the body always tries to reach homeostasis with its environment. And the one thing that we have seen over the last 60 plus years of spaceflight is that the body is really good at adapting. But with that adaptation comes some physiologic consequences. For example, there's a 3-to-1 ratio after a 6-month mission on bone loss. It takes, for example, if you're there for a year, like Mark Van de Heij, who we're about to bring home, it'll take him 3 years to be back at his normal bone afterwards. Now we try to retard that with bisphosphonates, vitamin D, resistive exercise, but nothing quite replaces Mother Nature in 1G. We can retard a lot of those things, but it just doesn't get there. And we've looked at things like artificial gravity, but despite what Hollywood shows you, where somebody's running in what looks like a hamster wheel, in order to get 1G, that has to be a pretty large hamster wheel. Otherwise, you want to keep the cycle less than 2 revolutions per minute. Otherwise, you get a neurovestibular impact to it the whole time. And so what we've seen is the body's good at adapting. What we have learned over spaceflight is all the different mitigations that can extend that endpoint, if you will. And I think that's one of the values of doing spaceflight, but also a lot of what we learn for spaceflight then applies to the ground as well, and vice versa. And I think that's probably one of the things that we need to do more of on our marketing, if you will, at NASA is talk about all of those things and how they impact the research on the ground for the ground population.
Great. I see a question from Dr. Christian Guy. Are there ongoing efforts to extend sleep or induce stupor and other states of decreased metabolic rate for extended spaceflight missions, such as those to Mars? So what work is being done regarding suspended animation and sedation?
Yeah, I'll take that one too, and let the others chime in. We have looked at torpor, but if anyone's ever put a patient into hypothermia after a cardiac arrest, you know that it's not as sexy as Hollywood makes it out to be. That you've still got IV fluids, you've got TPA, and you've got oxygenation. You can slow down the metabolism, but you don't stop it in total stasis like you see in some of the movies that occur in Hollywood. And we've looked at studies for those, but there's some risks there, believe it or not. Even in torpor, although you might be in decreased metabolic state, radiation is still pounding away at your cells. And then if I wake you up all of a sudden, 6 months later, now all of that reactive inflammation from all of that damage from the cosmic galactic radiation, instead of being spread out over 6 months, is now cascaded, and you're having that inflammatory reaction or the cell death and all of those things occurring all at once when I wake you up. And so that there is no panacea that will be helpful for really long duration exploration, but that's the importance of the research, is going to see what are the pros and the cons of each of these. But we have looked at torpor, and it sounds really interesting and it looks interesting, and we're still going to do some research there, but it has its own pluses and minuses.
So a couple of you have mentioned radiation in the chat, and it's come up several times. So maybe Dr. Saary, you can explain further. It seems to me that we should be able to shield people from radiation. Certainly in the operating room, we use lead coverings, and those work for the types of radiation to which we're exposed. Why is this such a challenge that we can't shield astronauts from radiation in prolonged space missions?
Well, let me first say lead is really heavy, so flying lead is probably not practical. But the biggest shield we have from radiation is actually the fact that we're on Earth, we have an atmosphere around us. And so as we go to space, we don't have the same protection. So there's radiation we can shield on Earth. It's not the same radiation. as we have in space. And interestingly, with some of the galactic types of radiation, galactic cosmic radiation, indeed that radiation is so strong it penetrates pretty much any attempt at shielding it that we are aware of at this point. Although, research continues to try and understand the mechanistics. The problem with learning about that kind of radiation is we can't really replicate it very easily here on Earth. So a lot of the research is actually being done on station related to radiation. And indeed, and I think I mentioned in the chat, when you try to shield from some of these forms of radiation, because they are so different from the radiation that we have on Earth, shielding itself actually can cause more problems because you end up then having scatter and you end up risking increased radiation exposure. One thing, and when we talk about radiation, we often talk about shielding, but one creative way to think about radiation, recognizing it has impacts on both acute health, on potential chronic health because of its risk for cancers and other types of inflammatory reactions in various systems, including cardiac and brain, but also the fact that it impacts epigenetics, is whether or not there's anything we can do to protect against radiation. So radioprotectants, and I know we all said we're not mentioning off-label use of medication, so I won't go into detail about studies related to the possibilities, the types of medication and the types of substances that may have value somehow in becoming protection if they are taken in advance. I don't think we know the answers to all of that, but I'll leave it at that if there are other comments from Jim or JD.
Michael, at least we think of radiation in three different ways. You have the radiation that's trapped in the atmosphere, and then you have solar radiation, and then you have cosmic galactic radiation or galactic cosmic radiation, GCR. The way I teach my students is, think of solar radiation as lower energy particles that you can shield. We can shield that with a spacecraft. We can shield that with your example of lead. Actually, the best shield is hydrogen. So water, even the hydrogen that's in a plastic water bottle, that type of, and in fact, the astronauts, when they know there's going to be a radiation event or a coronal mass ejection, they all get behind, the water bags at that area. That's their safe haven on the ISS. I also suspect that they take their radiation badge and stuff it in the water bags on occasion, but nobody will ever admit to that. But then there's the galactic cosmic radiation, and think of that as a high energy transport particle. Think of iron, a large atom of iron coming from outside our universe, zipping through at a very high rate of speed. There's nothing that I make on Earth that is going to block that. And that is going to go right through a lot of materials. Think of it, when I explain to the students, I think of coronal mass ejections and solar radiation as a shotgun with multiple pellets, which you can block with a sandbag. But the galactic cosmic radiation is like a high-powered rifle that goes through the sandbag. And so those are the ones we worry about because they're going through the astronaut and creating damage to those cells. And those are the long-term risks for cancer, whereas coronal mass ejection is acute radiation sickness that we worry about.
Great, thank you. That's very helpful.
Right. So thank you. Dr. Shrikantha Rao is asking about transfer of technologies and wireless monitoring in space and how that can trickle down to ORs on Earth. So examples of shared technologies.
Well, the one you mentioned goes back to the 60s, actually, and the way the telemetry that we're familiar with back from the 60s, for EMS, actually was first done in Houston. And the Space Center is like about 35 miles from the medical center, and they're out in the middle of cow pastures, basically. And somebody asked that very question. So they actually had one of the aerospace comm companies work with NASA and the fire department in Houston and set that up. And that's where it was first done. and then popularized that, you know, it's ubiquitous since the 60s. So, I mean, that's a very concrete one, but I think there's a lot of interplay back and forth. So much of the stuff that's come from spaceflight, from Department of Defense, you know, goes over to the private sector and back and forth. I think I don't know if JD would agree, but I think the flow from NASA to the private sector, it was 90% that way in the beginning. I think it's not that way now. You know, I mean, there is some certainly, but things have progressed quite a bit the other way. So there's still give and take, but not quite what it once was. But there's a mutualism there.
Mm-hmm.
I'll add a brief comment if you don't mind on that. So over the course of time, I think, I mean, if we ask the 97 participants that are still with us, how many of them are wearing some sort of watch that monitors their heart rate, or, you know, is a step counter? Yeah, we all have one on, right? You know, it's become just essentially part of daily life. Some of this monitoring, a part of that is because the data we generate is valuable. But an interesting thing too that happens in terms of the oscillation and the back and forth, as Jim mentioned, you know, is the process of incentivization in the commercial sector for generating interest and triggering massive leaps forward. And so an example would be for the Tricorder X Prize, for a multi-million-dollar prize for the first team that can generate or approve you know, non-invasive wearable diagnostic for 12 conditions, something. Those incentivization schemes have become more and more common. Not only, I mean, I think it's safe to say the biggest incentivization scheme that many will recognize is the Saary X Prize for the commercial space. But after that came a bunch of other ones, and this kind of wireless tech monitoring is included in that.
Great. There's a question in the chat from Gil Stam, who's asked a couple of questions, but this one that I'm going to highlight is, I think, one on which all three of you might wish to comment. And it's, what is the biggest challenge and most promising solution to making long duration missions medically self-sustainable?
I'll let Jim go first on that one.
Yeah, nothing difficult in that question, so good luck.
Well, I'll take the one that I don't think we have a good answer to. I chaired a National Academy committee, I guess almost 20 years ago, that was looking at this. And you know, certainly there's many of the basic physiologic things we've talked about already, such as, you know, cardiovascular deconditioning, fluid shift, disequilibrium. But one of the things that they thought was actually one of the most problematic was the psychosocial aspects. And that was when you have crews that are in very confined, volumes. You know, space station certainly is much more than we've had in shuttle, but in we're not going to go to Mars and something has the volume that the space station does, right? So that's not going to be typical of that. So when you look at, you know, you're going to have a small group of people in, you know, probably in many cases a volume less than a minivan, you know, or something like that, for 3 years. Does anybody see any problem with that? Probably most people dread driving with their kids cross country for 10 hours. Now imagine, you know, you're going to take 6 people that you're crewed with, and now you're going to be there for 2 or 3 years. There's issues. And some of these things go to even some, I'll call the political issues, where we have multi crews, multinationality, ethnic groups, racial groups, religious groups. I mean, you can slice and dice them, gender, all kinds of things. And if you look at analogs, for instance, with mountain climbing expeditions, Himalayan expeditions are often looked at. Some of these things are hugely a problem. And it's like, which diversity do you want? Which diversity don't you want? How do you really select, you know, in the coping strategies that many people have? Some people have better emotional intelligence. That's not a term that was used in 2001, but then others, you know, and there's just some people you wouldn't want to do that with. How do you go about that? So there's both scientific questions, there's political questions. You know, you might say, hey, one country suggests a few crew members, and you go, I don't think any of those could be in somebody's couldn't drive to the stinking mountains to go skiing without killing somebody. So those kind of things are issues. And I think that's still a challenge. I think we have less closed form solutions to than others. And I'll throw the others to Joan and JD.
Go ahead, Joan.
You go first. I'll hold.
Well, to piggyback off Jim, one of the things that we've found is the astronauts assume that the world is not going to change. You know, you leave to go to the space station, you assume that the world is going to be the same when you get back. And that has not been the same or the case in a couple of cases. Frank Culbertson, for example, launched to space. September 11th happened. Think of all the changes that occurred in security and TSA and everything occurred that after September 11th. When Frank got home, it was a much different United States than when he left. Sergei Krikalev, one of the Russian cosmonauts, launched from the Soviet Union, and the Soviet Union fell and became the Russian Federation. And then when he got home, his passport was no longer valid, and his country had changed names, changed flag, changed in a host of different ways. And so, you know, then you take that for a Mars mission. You're going to go for 6 months there, stay for 18 months, 6 months back, literally a 2.5 to almost 3 year mission. You know, the world can change a lot in 3 years. And so it's, those are some things that I think are challenges for crew members as well. And of course, radiation, always our long pole in the tent. So I always root for the engine guys. The faster we get through space and get to Mars, the better. You know, time, distance, and shielding is important for radiation. And if we can get there faster, then that's less radiation I have to deal with on the backside. So, agree with Jim on the psychosocial aspect.
And I'm going to chime in and say we're 3 for 3 on that topic. You know, there's some training that can occur in expeditionary behavior, but I think if we, and I hate to use and bring COVID into this, but we have learned about people's need for meaningful work, for valuable leisure activity, for good food, for social networks, and the significance when those things are interrupted. And when you think about a long duration mission, you think all of those things are likely to be interrupted. How do you mitigate that? And another thing too, which JD alluded to when he was talking about the impact of radiation as well, because there is a potential for nervous system damage, which is one thing I think about is how do all these things interact one with each other? Because then you have the issue of, well, then you have circadian disruption on top of it, and you have the changing day-night cycles, and you have, nutritional effects on top of it all. So it's not just one thing, it's how the whole picture might impact the mental health situation that could be really concerning from a long duration. How do we mitigate this type of question? Over.
Michael, if I could add one other thing, as we were talking, it might be that the people in the audience have seen the movie The Martian. Okay, I think the book is excellent, and I would tell you from a crew standpoint, I remember when it came out, and many of the things how he survives on the Mars is fiction. I mean, that's not going to happen. The things that I think many people thought were preposterous, and they actually do in the movie pretty well, is really true. And that's the difference. What are the people in mission control thinking and doing in the discussions versus what's the crew think? And there is often a huge schism between what the ground is going to tell the crew and what the crew knows. And, you recall on The Martian, like they decided they were kind of mutinying and how they were going to try to rescue their crewmate. I mean, we have situations that I've been part of on both sides of that, where they say, well, the crew doesn't need to know this. Here's something that happened, whether it's with a family, something's happened to a parent or a child, this will just distract them. Well, that might be a good thought, but then if it gets through, then the crew thinks, well, what else aren't you telling me? Or we've had situations on a mission that I flew on the space lab, where there was a problem. One of the crew members had a problem with a piece of equipment and basically made it non-functional, and they'd given up on it, and they said, don't try to do anything else. We're going to give up that entire experiment. But yet they didn't understand what we knew. And, they trained in their silos, so to speak. And I remember that I took the heparin syringes, the 2X syringes, and I used the needle. I cut them off and made 27 gauge pins and a 7-pin connector. And we revived the entire experiment and got all the data. The ground said, you can't do it, we're throwing it out. And we go, I think it will be. And we did it, so we used the initiative. At first it caused some dissension back and forth, and then it worked. But communication is a huge issue. How do you have clear communication? Sometimes the crew thinks they're being paternalistic. And we've seen, even when crews have come back, where there was such a schism in trust between people in mission control and the crew. Some people didn't talk to each other for a long time. And these are big issues. How much do you, I don't think there's a right answer. I think it's a very difficult answer. It can have very profound effects. That it's not just with the crew, it's the crew with the ground. And I think the Martian, I don't know about JD, you don't have to incriminate yourself. I thought some of the things they said, that we see things like that. That wasn't as theatrical as people thought. It would be my own opinion.
And just to follow up and understand, you referred to these social issues and really that being a big challenge. So I'm trying to imagine, some of the people questioning, are we really doing the session live, or is this not live? And I'm saying, yeah, this is live, we're really here. But then could we send zombie versions of ourselves to Mars? In other words, I know you were talking about the difficulty of suspended animation, and we can't do that. But how much work do you actually have to do on the journey? And can't you just have pharmacological or electrically induced sleep or some other state of animation allowing that passage of time to seem trivial? Would that be something that would be conceivable? Because that's the problem, being in the minivan for however many months.
Yeah, I'll tell you, if your minivan is never going to break down, you're in good shape. But the problem is on ISS, it's a house that is being bombarded by radiation, that is having to change its vector, its state vector, and its solar panels and all the things. Murphy's law follows spaceflight very often, and a large portion of what the astronauts do, in addition to their science and their research, as Jim well knows, is maintenance on the space station and repair and other things. So that it sounds nice, on that we would be able to relax or be in stasis going to Mars for 6 months. The reality is they're going to be working. They're going to be working on multiple things. Sometimes they're working on themselves, exercise, for example, to keep that bone in place. Sometimes they're working on the spacecraft to keep the solar panels oriented, or because a bus has quit working or something else has quit. But although the suborbital folks make it look easy because they're going up and they're coming down, and so it's great to be a passenger. We don't have many passengers, at least at NASA. They're pretty active and they're working a lot. And we have these folks called ops planners that plan literally every minute of the day that these folks are working, and their work is filled throughout that day on the International Space Station. But Jim can talk about that from a first-person perspective.
So I am mindful of time because our session has come to a close far too quickly, and so this conversation needs to continue. And I just want to thank our outstanding speakers for their wonderful presentations and this conversation. I also want to let our delegates know the work and preparation that went behind this session. I know Michael and I were so impressed with the telephone calls and emails and communications that was occurring by these distinguished speakers preparing for this session, and it showed. Thank you. We've learned from you the way you work, the way you work together, and we are just so deeply honored and thankful for what you've done for us today. So thank you so much. Michael, over to you.
I want to echo everything Bev has said. What a privilege this has been to be moderating this session. You are terrific speakers and have been so inspiring to Bev, to me, and to everybody who has participated in the session, as you can see from the many messages that are being left by our colleagues. So thank you so very much, Drs. Bagian, Polk, and Saary. We are honored to have had you at this year's IARS meeting. And thanks to everybody in the audience. See you all in Colorado next year in person for sure. And we will banish COVID forever.
Thank you. Bye.